Okay, starting on slide 95, multiple gestations. The book just references the monozygotic twins versus dizygotic twins. And the monozygotic twins, just a reminder, it's 1 egg and 1 sperm, and the dizygotic twins is 2 eggs and 2 sperm. Pregnancies with more than 1 fetus just carry some general increased risks for the woman. They include hypertension, things like anemia, gestational diabetes. With the uterus being larger, she does run a greater risk of going into preterm labor. Also, when we have a uterus overstretch, that muscle might have difficulty contracting after delivery, so she is at an increased risk of hemorrhage and abruption as well. To the fetus, the increased risks include fetal morbidity, mortality due to sharing uterine, due to sharing the uterus. Sometimes there can be complications such as twin-to-twin transfusions, where one twin is receiving maybe more nutrients or has a greater blood supply than the other. Also, preterm delivery we know is going to put our neonate at a greater risk. One of the greatest risks is being that causes respiratory issues. Also, we have an increased incidence in low birth weight with preterm babies, and I think that covers about everything on that one. Assessment findings. Many times when someone has multiple gestations, they have when you do blood draws in the beginning, they have a higher level of HCG found in the blood. That can be an indicator. Also, when you're doing a fundal height, that may be indicative of, they might be only 20 weeks along and you do a uterine measurement and they're at 24. They also have what's referred to as round ligament pain, which are the ligaments on the side that hold and stabilize the uterus. Those stretch and usually can cause some more severe pain. Some other things, sometimes the increased level of hormones might cause a greater susceptibility to morning sickness, nausea, and vomiting also. Multiple gestations is usually diagnosed now with ultrasound. Sometimes it might first be noted with a fetal Doppler, and they might notice 2 different heart rates in there, one of not being the mom's. Caring for a patient with multiple gestations, when you're thinking of the antepartum period, a lot of times their nutritional needs are greater. We're going to talk about, continue to talk about some of those risks that they're at and how we will have them do kit counts. They might come in and do NSTs more frequently. We're going to be assessing them for gestational diabetes, hypertension. Usually they're monitored a little more frequently, especially in the last term of pregnancy. Usually you start seeing them about every week in the last term. Intrapartum. You're going to be, when you're caring for this patient, you're going to be thinking postpartum also, knowing that they're at a greater risk of a postpartum hemorrhage. And also, we need to make sure that we have sufficient team on staff to care for them. Sometimes these patients deliver vaginally, sometimes they deliver by C-section. It's all going to be dependent on the position of the baby. Most physicians will not deliver them unless they are both head down. So they may be a scheduled C-section. Many times their scheduled C-section is around 37 weeks instead of waiting until that standard 39 weeks. Nursing actions. Many times we need to assess for complications with the patient. Make sure you're looking at that NST. When you're looking at that NST, we need to make sure that we have a good, clear picture of both babies on the fetal monitor strip, and that you're getting 2 distinct different tracings. Also, a lot of assistance with emotional support, teaching them about postpartum things in preparation for deliveries, such as how it's much better to get the babies on the same schedule. They're going to need extra help after delivery.